So while people are finding their seats, a little bit of housekeeping here. The way we will do this report out is that each of the 4 individuals that you see up here, including me, will do a 5-minute presentation of the group, and then we hope that we'll have approximately a 20-minute opportunity for questions and answers and continued dialogue with all of the rest of you to be sure that we sort of got this right. The first 2 breakout groups will be on the envisioning national surveillance. The next 2 will be on accelerating research and translation. And so it is now my pleasure to ask Dr. Atkins to come up and to provide a summary of the first breakout group.
Okay, so first of all, I want to thank the group that was in the room with me. It was a very, it was just an excellent discussion, and I think that we have some very important points to make. If we could have the first slide. Or do we have the, okay, next. Okay, so the first thing that we discussed was the potential partners in a national surveillance. And we started the discussion. The planning committee had come up with about 6 potential partners, and my group dramatically extended that list. So the first would be the federal agencies that we have all worked with: CDC, FDA, NIH, NHTSA, HHS, and DHS. Professional organizations, and these are both voluntary organizations and those organizations that physicians belong to as part of their professional lives. The Heart Association, the Red Cross, the American Hospital Association, NAEMSP, ASAP, American Academy of Pediatrics, Public Health Association, and Heart Rhythm Society, all of which have some role either in cardiac care, and we probably actually should say American Heart/American Stroke Association. So a variety of organizations there, but all of whom have some interest in cardiac arrest and outcomes. Clearly, and this is stated in the very first recommendation, state and local health departments, EMS, law enforcement, and then obviously the citizens of our country. Payers have a role in this as well. The existing registries, of which there are several, and then industry, and we have included the computing industry, Google and IBM Watson that we just called out very briefly. Biomedical, those industries that are involved in the equipment, the devices, the medications, everything that we need to provide care to the cardiac arrest victim. And then electronic health records, the vendors for that, the EPCR, and the data standard organization. So clearly not a fully comprehensive list, but there are very many potential partners who do have a vested interest in cardiac arrest and its care. Next. And so then we spent probably about half of our time discussing the issue of existing data sets versus a brand new data set, or somehow combining data sets and building on existing. And we talked about pros and cons. There are many extensive data sets. They virtually, in some form or another, have demonstrated their worth. They have been very useful to document changes in disease, and there are existing partnerships with the current data sets. The cons are that they are multiple right now. They can at times be fragmented. Accuracy may be a question. They have variable funding. There is not always good cooperation and collaboration. All of them right now require voluntary participation, and there may be data collection problems with EMS. Next slide, please. So we talked about the requirements for modifying existing data sets. I would say, although our goal was not to come to consensus in our room, it did seem to me that probably there was a fair amount of support for at least starting with our existing data sets and really not starting from ground zero, because if we started from ground zero, we really wouldn't have made much progress in the next 5 years. We felt that the requirements for modifying existing data sets would be that there would be a minimum required data elements with optional elements to be added as EMS agencies had time and resources. We thought that it was very important that the data sets be able to track the data. And this is more than just, tracking it and keeping count of it, but what is the percentage of the population that's captured, and what is the minimum data set that's actually captured of those that are entered, with obviously a goal of increasing both of those so that we would get as close to 100% as possible. There need to be feedback mechanisms. EMS, hospitals, and communities clearly need to receive feedback as to how well they're doing, the benchmarking. It provides for them a huge motivation to actually sit down and enter the data correctly if they are receiving information back which helps them in their care. We need to somehow document full ascertainment. There is no data set right now that actually can say that they have entered every single patient who suffers a cardiac arrest. We have EMS data where only if you receive EMS treatment. We have EMS where EMS was called and you did or did not receive treatment. But we may not have those patients who perhaps die in their homes for whom EMS has never contacted, but they still had a cardiac arrest. It was pretty clear in the group that based on our organization of cardiac arrest care, that there needs to be a local and state control management and accountability. And then obviously we need methods to improve and make the ease of data entry easier. Obviously automated data entry where it may be entered into a record for another purpose, but then captured and transmission. We need a data linkage and interoperability. Next slide. I don't know if I can operate this here or not. As I implied, there was not much support for development of a completely new data set. The pros of a brand new data set, that it be mandatory, that it be transparent, that it would have ultimate cost savings. Many of those objectives can be achieved by making modifications in current data sets. And the cons would be that it would probably be extremely limited funding, and the biggest objection to it was the time commitment that if we started from scratch when a lot of work has already been done. Next slide. We spent a lot of time talking about sustainability, probably at least a third of our discussion time. The issue of funding is always top and center. And the suggestions were made that we fund for measurement and we fund for process, so that you either get something in return or you're actually not paid unless you participate in measurement and process. Basically, the model that CMS has taken, that if you don't participate and follow the guidelines, then you won't be paid. Again, the ease of data entry is going to be primary for sustainability. If it takes a lot of personnel time for this particular objective, it's not going to work. Again, we need interoperability between health records with EMS and hospital. Right now, those don't exist. Most of the electronic health records that are used in hospitals cannot interface at all with EMS records. We will clearly need data linkage between out of pre-hospital, hospital, and potentially even post-hospital. And then in some manner, whether it be financial or other, to incentivize individual systems and people so that the data are entered. And then the one comment that was made that I thought really summarized a lot of this was pull sustainability actually out of the data. And I think what that person meant was, if in the process of feedback, people are encouraged to continue to submit the data, obviously if there is some incentive for submitting the data, then you also maintain sustainability. And I think that's the conclusion, yes.
So I want to congratulate that group and quickly report on the summary for the second group that considered surveillance. Advance. Oh, I guess I can. So we did talk a lot about the barriers, and I think they can be summarized by the numerous registries, lots of data, but no definition of the optimal registry and no nationalized, standardized minimum set of data. We know that implementation is time-consuming and can be costly, and cite the need for an efficient, scalable process for state-level cardiac arrest registries. And the one thing that we all know is data is being collected but not shared. So I'm not going to review the partners. Our partner list was very similar to the list that Diana put up here, with the note being that we really think the agencies that we really need to partner most heavily with include the CDC, FDA, NIH, NHTSA, and that we are going to eventually have to determine kind of which agency is most accountable. We also should be defining which of the non-governmental organizations have a mission that is focused on cardiac arrest. So we spent the bulk of our time really talking about the options to advance surveillance within the next 5 years. And very much like Dr. Atkins' group, we really believe that building upon some form of our existing data sets is probably the most fruitful way forward. We recognize what a Opportunity Cares is in terms of the work that's gone into it. It's been affordable, it's been rigorous, it's been published, it's improved patient outcomes, it's secure, it's high quality, it's comprehensive. And the notion was that we ought to build on this foundation. There was also discussion of American Heart Association databases that have some similar characteristics, but the idea being that we would build upon existing data sets. One theme that came through was sort of this idea of marketing. I want to hit that at the end. Clearly, a notion being that it's difficult to obtain stable and sustainable funding in the current environment, and that one of the most fundamental problems that we have is this lack of accountability, one similar to something the other group identified, where we know that surveillance can and will indeed promote accountability through the identification of issues in cardiac arrest. And so we really are desperate for this. And so I think the notions that people really agreed upon is the idea that we ought to establish cardiac arrest outcomes as a national EMS and hospital performance measure, that there's a need for mandated cardiac arrest data collection and the need to establish cardiac arrest as a reportable condition, the need for data, it has to be accessible to the public and comparable across communities. One of the great suggestions that actually one of the survivors raised is that how ironic it is that crime statistics are available for every community, yet cardiac arrest statistics are not. And that there's reporting of crime in every community. It's not really a voluntary sort of thing, you know, oh, you can report your murders, or, oh, you don't have to report your murders, you know. We don't do that, and the result is that that data percolates up at the federal level and then percolates back down to the local level where indeed communities respond to that, and we simply have to get to something that will eventually move us like that. I think the final sort of summary of our group was the notion that whatever we do, it has to be easy. That is, it has to not be onerous on any group. It has to be cost effective, and it has to be mandatory so that all communities are protected and there can be insights from each community so that those communities can ultimately improve their chain of survival and their outcome. So now, who would like to go first? Art, do you want to come and present the on the research?
Oh, okay, thank you. Okay, so we had the recommendations, which I won't repeat. Just to get to the focus point, first I'd like to thank everyone who participated in this discussion. It was a very lively discussion, and we had some really good ideas come out. We just had 3 focus points that we'd like to emphasize to the big group. And 2 of them came from the speakers this morning. This came from Dimitri's presentation, which is explore the use of a bundled funding mechanism to identify and support common research goals and at specific points of time. And the specific points in time is crucial. So potential partners are national funding agencies, federal agencies, private companies, industry, health insurance companies, other companies that may be interested in this. Similar to the mechanism that used in Europe that was described earlier today. And the point is that at this point in time is very different. I think Bob Berg mentioned earlier, 15 years ago, we were really interested in doing more clinical trials. At this point, we might be more interested in developing young researchers, developing more laboratory studies to see what's necessary in the future. And as we also felt, for example, implementation studies, disparities issues, and to identify what is really there that the top issues that the funding should go for. Our second point is methodology issues in clinical research. And we felt this was an important point to be addressed in future clinical studies, consideration of more targeted studies like the adaptive trial, stratified patient groups. We felt the need for standardized definition as much as possible to try to do individualized programs so that potential treatments are individualized protocols for specific patients. So it may be VFib-RS, it may be pediatric or whatever, but it's individualized would be the goal to get to patient-centered research. And then also to address issues like disparities and confounders that may have been a problem in previous studies. And then our final point is we really stress the use of implementation science. We felt this is the time that we really need to focus on that and put a lot of support into it. And the issue is we know a lot of what to do, but it's just not being done. So how do we do that? Use of implementation sciences to assess gaps in healthcare systems. A big issue is disparities. Why is one hospital have real poor outcomes and another hospital in another neighborhood maybe have good outcomes? And then the second point, this is taken almost word for word from Dr. Gibbons, the adoption of effective and implementable practices to improve survival. So why do some systems and hospitals have excellent survival rates while others have poor survival rates. So we need to do more research. One of the things that came up was, is this simply a Hawthorne effect? And we certainly support a mandatory reporting and comparison of data, but it may not be. It's probably a combination that's part of it. And then there are certainly examples of communities that have put together excellent improvements of their survival rates by developing their own reporting mechanism. So while we support mandatory reporting, we'd say do it anyway, get the implementation science to do the best for each community and each hospital. And those are our 3 points. Thank you.
Go ahead, Jeremy.
Thank you, Art. So we were the other group that was looking at research priorities, and we also really benefited from a great discussion, as well as what I think is the nicest room at this beautiful building, the members' room with its lush wood paneling. It was a pleasure to be there. Okay, so we mentioned the partners that we would look to, and actually we had some that I think we haven't mentioned yet. These included telecommunications firms, the Verizons and AT&Ts of the world, who might be interested in learning more, especially as more and more people wear devices that transmit data. So I thought that was a very interesting suggestion. Other suggestions, including the Rotary societies, which are apparently a society in need of a mission now that polio has been cured. And that is just a fascinating suggestion, as well as others that you might, of course, have thought of, like the American Association of Retired People, who are already targeting me, apparently, even though I'm a little bit way off. So we have a number of potential partners. The thing that we really struggled with, I think, is figuring out how to raise more money for this venture, because, as has been said many times, without funding, all the goodwill in the world will not go very far. We spoke briefly about what it is that we are trying to do, and we mentioned some of these issues, but I want to bring to your attention one that really resonated with the group was this lack of public awareness, that it doesn't take long to speak to a small group of people and find out how many of them have a first-degree relative or friend who suffered a sudden cardiac arrest. And yet when you ask the public about major health challenges and problems, cardiac arrest does not necessarily rise to the top or even make it into the top 10. So we really felt that through educating the public and then the public's advocacy through their elected representatives and other ways of raising money through private public partnerships, cardiac arrest research can really be taken to the next level. We also mentioned some of these other problems that the IOM report also referred to, specifically the lack of funds to implement evidence-based findings, and as the last group reported, this great degree of variability between different EMS agencies and hospital groups. So, of course, everything comes to more money for NIH, but we realize that this isn't easy to make happen, and that the most effective way probably is to simply have more advocacy from the public. And the challenge here is, of course, to make sure that the branding, we had a marketing expert in our group, which was fantastic, to make sure that the branding and the nomenclature of what it is that we're trying to do is clear to everybody, because, of course, what is clear to members in this room may not be clear in members of the public. We really want to emphasize that we need good investigators, and therefore funding of future cardiac arrest researchers and ongoing training is very important. We also mentioned that the National Heart, Lung and Blood Institute has somewhere in the region of 100 T32 training grants. I'm not sure how many of them are in the area of sudden cardiac arrest, but they are certainly heavily invested in the space of training cardiovascular researchers. In terms of public-private partnerships, we've already mentioned some of these. It is also important, of course, to include areas in which there may be some socioeconomic disparities and rural areas as well. And the suggestion that was made on the last slide, I think you really emphasized this, was that cardiac arrest isn't only a question about the heart, it is a question of disparities. It's a question of why some areas of the country do extremely well in recovering people with sudden cardiac arrest, and other areas do far more poorly. And even within those areas in which there is success, how are minorities, how are different sexes, the outcome of different males and females. Minority health is a really important part of this. And so I think the notion that making cardiac arrest a question about disparities is really front and center of this effort. I think the biggest trouble that we had... 5 seconds. The biggest trouble that we had was deciding who is going to put this all together for us. Who is going to convene these groups? Who is going to convene the partnerships that we've suggested? Who is going to bring together the Ford Foundations and the Gates Foundations and the Kellogg Foundations of this world and sit down with them and have them raise money for this venture? Without there being a single convener, it's going to be very difficult to put this into practice. But we did come away with the realization that we really do need to bring these groups together so that we can have a sort of a one-stop area where cardiac arrest can really feel that it has a voice outside of the federal government. Thank you.
So, thank you, Jeremy. We've got just a few moments for some questions and comments to the audience. Did we get this right? Or to the panel? And one of the themes I just want to comment on really quickly that was recurrent in our group and possibly in yours is how interconnected many of these things really are. That you can imagine how research has to do with surveillance. We talked about marketing in our group and the need for advocacy and to have the public face, to have public involvement. Where's the voice of the patient? Well, if we don't have that, how do we get surveillance? And sort of the connection between that. I'd now like to open it up if people will approach the microphones for comments from people from the audience. Art?
Could I just make one quick comment as to who's going to bring it together, who's going to bundle all of these things. Recommendation 8, the collaboration, tomorrow will be discussed.
Art has the answer. It's terrific, and he's exactly right. Any other comments from the floor at the first microphone? And again, for those of you who are just joining us, please identify yourself and your affiliation, and be brief because we don't have a lot of time.
Nickel from the University of Washington. I apologize for those in the room, to those in the room who I'm about to offend, but it has always puzzled me that 40,000 women a year die of breast cancer. And there are multiple very large, very successful charitable organizations that advocate for improved breast cancer care and research. And there are 350,000 people who are treated for out-of-hospital cardiac arrest a year, but there's no similar organization for cardiac arrest. Maybe we need a Susan B. Komen for cardiac arrest.
So again, that linkage between marketing driving so much of it. Another comment here.
Scott Kier, I'm a paramedic with Newcastle County EMS. One thing that stuck out to me there, establishing cardiac arrest outcomes as a performance measure. I'm going to preface this by saying that I agree with that 100%. The devil's advocate side of that is the one consistently reported measured performance measure in virtually all systems is response times, and people are very reluctant to go farther than that. Just food for thought, rhetorical question, however you want to deal with it. Do you think people are going to buck that when you start asking them for more, and how do we get over that hump?
My first, what I think people would say is that's, I think, why ultimately it has to be mandatory or reportable or required, or there has to be some element of a requirement brought to the data, because I think it's all of our experiences that if there's nothing, if it's not required, places will opt out. And what I can tell you, having lived in some of those places, is they are not the best places. okay? And so that's really the issue, right? That if we want to protect every community, I don't think that can be an option if we want to move forward. Please.
Bob Newmar, University of Michigan. I was in the breakout session for research and how to move research forward. And I guess the message that we heard in the breakout session from NIH, whether it be NIH funding or public-private partnerships with NIH, that we shouldn't expect any additional funding from NIH unless there's new money to go into NIH. And I just want to make sure we have some clarity on that. Is that what the message is?
So I work at NIH, but do we have anybody specifically from NHLBI in the, is David here?
And particularly anybody who would like to answer the question. That's really, like, there might be somebody ducking down at this point.
Otherwise I'm going to be forced to answer the question. Look, it's very simple. Currently, NIH funding is essentially flat at about $31 billion a year. There was a small increase. It's not even a cost of living increase. And the funding to each of the institutes is fixed. If NIH tomorrow will get a 10% increase, that will more or less equate to a 10% increase for each of the 27 institutes and centers, more or less. So the answer is yes, unless more money comes in, or unless you can persuade an existing institute to allocate its money, and we spoke about this in our meeting, unless you can persuade an institute to take out of its general fund a specific dollars and put them aside for a specific project, then there is no new money to be allocated.
I guess for clarification, is it worth our efforts to try to convince an institute within NIH to allocate more money to cardiac arrest or not? It's more, where are we going to put our resources, where are we going to put our efforts? Because, again, the message was it didn't sound like that was going to be successful.
I'm not going to answer that second question. I'll leave it up to you to decide whether that's something that, we really need the leadership of NHLBI to address that question. I wouldn't be able to answer that for them. But I will
So
say,
Dr. Newmar, one of the things you're alluding to, but you haven't said, is that, and I want to give you a chance to address it, are you also suggesting, as was pointed out in the report, that there's actually a disparity within the allocation of the NIH dollar? Or are you simply saying that the NIH needs more money?
Well, yeah, we actually had a good discussion, and NIH has published a nice graph that's showing that there's disparity across the board in terms of how NIH funds research relative to burden of disease. So that disparity exists not just for cardiac arrest, but cardiac arrest is obviously on the lower end. But I guess if we're here to talk about implementing the recommendations of the IOM report, one of the recommendations is to increase support for research. And we need to figure out what our plan is moving forward. It would be good to know one way or the other whether trying to convince an institute to spend more money on cardiac arrest, earmark money for cardiac arrest or not, is worthwhile effort, or if it's a non-starter, we should just declare that and move on.
That sounds like a big question. Does someone else want to either take a stab at that or provide an answer?
So the one figure that's out there in published literature on the cost of cardiac arrest to society in the United States is $330 billion a year. The NHLBI NIH total budget is $30 billion. That's a statement of the problem. I think it's, having studied this issue from the point of view of alternative sources of funding, I think it's unrealistic to see sufficient increments in NIH funding in the foreseeable future, and that goes to bringing up the private-public joint venture kind of things with industries that have sufficient funds and can see a business model that will support their investment into research.
So yeah, but just one follow-up on that. Even the private federal partnership, it wasn't even clear if that partnership would be a co-investment or not. So,
And I just want to make one point, that the people in the room who are strong advocates for cardiac arrest research, and it's a wonderful thing to be an advocate for, shouldn't feel that they are alone in feeling that NIH isn't spending their money. My job is to attend meetings like this, and not so long ago I was in a meeting where trauma was addressed. And although cardiac arrest is way down on the list, there's one area in which the burden of disease is even higher compared with NIH spending on research, and that's trauma. So the trauma community was upset with that. And then I attended a meeting with the traumatic brain injury community, and they felt that NIH wasn't spending enough money on their particular disease. And in fact, I challenge anybody to find a disease advocacy group who will stand up and say, bravo, NIH, you're spending exactly the right amount of money, or even too much. Why don't you give it to somebody else? So the point is that doesn't mean that this group shouldn't move forward, but it does mean that we have to be realistic about what is achievable and what is available in the space of publicly funded research.
Very good.
Good afternoon. Tom Holloway from the Federal Aviation Administration. We've heard two excellent recommendations from the groups looking at research priorities to measure to research the reason for the differences in effectiveness and outcomes among different healthcare systems. I think it's very important to include the general public in our definition of healthcare systems, because if a person does not get bystander CPR and an AED within 3 to 4 minutes, their chance of survival is just about none.
Tom, while you're there, can I just pick on you since is aviation a voluntary reporting system? Do pilots voluntarily report kind of what their rates of mischief are, so to speak?
That's an area that is outside my area of expertise, so I will defer to my colleagues on that. But I think the answer is no.
Are there any other questions? Any other comments? I think what we'll do is we'll wrap up at this point. And it is now my pleasure to move on to the next panel. The speakers who are up here are excused. The next group can come up. Next up, it's my pleasure to introduce Marina Del Rios, who will be introducing the next panel and taking us through the next part of the program. And I want to thank everyone who participated in this.